All right, so what we're going to be covering today is going to be the lower extremity, and we're going to look at the hip, we're going to look at the thigh, we're going to look at the leg and the foot. So if you look at some of these thumbnails, we're going to see the entire lower extremity from the front. Then in this view, we're looking at it from the lateral side, we're just rotating it, and then we rotate it again to the posterior. Okay, and so let's take a look at the anterior view and show you what we can find here. So right up at the top, right here, we see two muscles, psoas major and iliacus. Now, combined, these two muscles are called the iliopsoas, but they are two clearly separate muscles, right? So over here you see psoas major, and that originates on the lower lumbar vertebrae, and it inserts on the lesser trochanter of the femur. The iliacus originates here on the iliac fossa of the ilium, but it too shares the exact same insertion site as psoas major, which happens to be on the lesser trochanter. So they're two separate muscles. The belly of the muscles are separate. Their origins are separate, but it does have a common insertion site. This structure here, going from the ASIS, the anterior superior iliac spine, to the pubic bone, this is the inguinal ligament. That's the inguinal ligament. So both these bellies go under the inguinal ligament and will attach on the lesser trochanter. So what do these two muscles do? These are the primary hip flexors. Hip flexion. So if you were to raise your hip up like you're trying to walk up the stairs, that's hip flexion when the hip comes up. I make sure you watch my YouTube video on ranges of motion. I break them up into ranges of motion of the upper extremity and ranges of motion for the lower extremity. Both of those videos are less than 10 minutes each. Now, what else do we see here? Right here is the iliac crest. You remember that from osteology. And then that bump is the ASIS, which stands for anterior superior iliac spine. And right at the anterior superior iliac spine, there are two muscles that originate there. One of them is the longest muscle in the body, called the Sartorius. Right here, it goes from the ASIS, goes down, right, it crosses the front of the thigh, and attaches to the inner inside of the tibia. So if you remember, here's the tibia, that's your patella. Here's your tibial tubercle or tibial tuberosity. And medial to it and posterior is an area referred to as the pes anserine. P-E-S, pes anserine. It literally means goose foot. It looks like the foot of a goose. When we rotate the knee, you'll see what I'm referring to. Sartorius is the longest muscle in the body. I refer to it as the Faber muscle. Faber, F-A-B-E-R, F-A-B-E-R, Faber. F stands for flexion. A-B for external, A-B for abduction. And E-R for external rotation. So Faber, F-A-B-E-R, flexion, abduction, and external rotation. That's what this muscle does. It flexes the hip or the thigh, it abducts it, and it externally rotates it. The Sartorius is also known as the talar muscle. The talar, aka figure 4, so if you sit with your legs crossed, or the figure 4 position, that is actually Faber. That flexes, abducts, and externally rotates the thigh. Second longest muscle in the body is this one here called the Gracilis. It goes from the pubic bone, and it too shares the same insertion site as the Sartorius, right on that pes anserine. Again, it's medial and posterior to the tibial tuberosity. Okay, what was the other muscle that originated on the ASIS? I call it the Starbucks muscle. It's the tensa fascia latae, right? Or tensa fascia lata. TFL is how it's abbreviated. But it originates on the ASIS, comes down and inserts. Now it's a little bit camouflage, but I'm going to zoom in a little bit. Right here off the iliac crest, we see this. It's also gray, so it kind of blends in with the background. But here is a soft tissue structure. I'm going to follow it down right here on the outer side of the quads. It comes down and inserts right there, but it's also grayish in color. When we rotate the thigh to the lateral side, we'll be able to see this band. It's called the ITB, or the iliotibial band, or the iliotibial tract, because it goes from the ilium all the way down to the tibia. So the TFL, the tensa fascia latae, inserts on the iliotibial band. And it's an abductor. It can flex the hip and it can abduct the hip a little bit. All right, what else do we have? We have these large, immense muscles in the front of the thigh. They're called quads, or Quadricep femoris. The term quad means four. So there are 4 quadriceps. 3 of them are the vastus sisters. We have here the vastus lateralis. It's a lateral muscle. We have the vastus medialis. And there's a third vastus, but we can't see it yet because the rectus femoris is superficial to it. So this muscle here, the rectus femoris, lies on top of the third vastus muscle called the vastus intermedius. Vastus intermedius. So you have a vastus lateralis, a vastus medialis, and right in the middle, deep to this one, is the vastus intermedius. The most superficial is, of course, the rectus femoris, and it's the only one of the 4 quadriceps that doesn't only cross the knee, but it also crosses the hip joint. So Dr. Lindner's rule of thumb, if a muscle crosses a joint, it has to move the joint, right? If a muscle crosses the bone and crosses the joint, it somehow has to act on it. So since the quadricep muscles here all cross over the knee and insert right there on the tibial tubercle, when these muscles contract, it's going to extend the leg, like you're kicking something or kicking a soccer ball. That's leg extension, aka knee extension. The rectus femoris also crosses the hip. So since it crosses the hip and it's in the front, it moves the thigh to the front. That movement is called hip flexion. So the rectus femoris can flex the hip because it originates on the anterior inferior iliac spine, right? This landmark here is the anterior superior iliac spine. If we were to dissect and rip away the Sartorius and TFL, we'd be able to see the origin of the rectus femoris on the AIIS. Since it crosses the hip, it can flex the hip, and it crosses the knee, it extends the knee. On the inner thigh are adductors, adductors, right? That means it can move your thigh towards midline. That would be the pectineus, the adductor longus, and the gracilis. There are a few other adductor muscles called the adductor magnus and adductor brevis, but they just adduct the thigh. Let's look down on the anterior leg. The anterior leg, we have muscles that originate on the front of the shin, where the tibia and fibula are, and these tendons cross the ankle. So again, if it crosses the joint, it has to act on the joint. Basic rule. So since it crosses the ankle in the front, what is that action called? When it moves the ankle up, we call that dorsiflexion. When the ankle goes down, as if you're stepping on your tippy toes, we call that plantar flexion. So you have dorsiflexion and plantar flexion. Anything on the anterior compartment of the leg that crosses the ankle, even if it attaches to the toes, we know that it will move the toes, but if it's at least crossing the ankle, it has to act on the ankle too. It's going to dorsiflex it. So again, make sure you watch my video on the lower extremity that shows and demonstrates what these actions look like, so you're just not memorizing words like ankle dorsiflexion. It really does help if you have a visual as to what that looks like. So the tibialis anterior, this is a really important muscle, folks, very important. It is the primary dorsiflexor. It's the primary dorsiflexor of the ankle or foot. But if you see the tendon, right, here's the belly of the muscle, the gray is the tendon, it attaches here to the inside of the foot, specifically first metatarsal, first cuneiform. That's why it's important to remember those bones. You can't just forget them. So first cuneiform and first metatarsal. So in essence, the belly of the muscle is attaching to the inner foot. So when that muscle contracts, it can invert the foot as well. Not evert, but invert the foot, meaning rolling it in. That's foot inversion. So tibialis anterior dorsiflexes and inverts the foot. When this muscle is weak, when that muscle is weak, and it can be weak because the nerve going to it is damaged. The nerve happens to be the deep peroneal nerve. That deep peroneal nerve originates in the lumbar spine at around L4. So I like to teach my students that L4 is your dorsiflexor because it goes to tibialis anterior, right? L4, tibialis anterior, dorsiflexor, foot invertor. They're all the same. That's the L4 nerve root. So if someone has a subluxation in the lower back or a disc bulge or disc herniation and it's putting pressure on the L4 nerve root, the foot gets clumsy and you can get a condition called foot drop. Why does the foot drop? Because you don't have the strength to dorsiflex it. Dorsiflexion is walking on your heels. If you can't raise your foot as if you're walking on your heels, your foot drops and your toes drag. That's a condition called foot drop. And when people have foot drop, they have this interesting type of gait that's called a steppage gait. And steppage gait is when the person walks, they raise their knees really, really high so the foot clears the ground. They raise their knee high as they're walking so that the toes don't drag on the floor. It's called steppage gait. You have all seen it before. I guarantee you've all seen it. You just didn't know it was called steppage gait before. Okay, in the front, we also have the extensor digitorum. If you follow it, it goes down, and you can see it goes to toes 2, 3, 4, and 5. So it's going to dorsiflex the foot, and then extends the toes 2 to 5. Why doesn't it extend the first toe? The first toe has its own muscle, right? It's a hallucis. It's got an extensor hallucis longus and an extensor hallucis brevis, as you also have of the thumb, except we call it pollicis. Extensor pollicis longus and extensor pollicis brevis when we talk about the hand. All right, so all of the anterior compartment muscles are innervated by the deep peroneal nerve. And they're all dorsiflexors. And if they cross the toes, they will extend the toes, also known as dorsiflexion of the toes. What we can see in the back, when I rotate this, you'll see it better, but on the posterior compartment, the two big powerful muscles are the gastrocnemius and the soleus. They are completely antagonistic to the anterior compartment. So if the tibialis anterior dorsiflexes the foot, the gastrocs and soleus will plantar flex the foot. That means stepping on your tippy toes. Okay. So that was the front. Now I'm going to take it and rotate it to the side, okay? So let's take a look at the side. This is anterior. This is posterior, right? That's the lumbar spine, and that's your sacrum. So there's the gluteal muscles. The large one is gluteus maximus. The one up here is the gluteus medius. And if we cut a hole, if we made a little square through the gluteus medius, that's where gluteus minimus would be. It's actually deep to the medius. All right, here is what I was trying to explain before that I said was kind of camouflage with the background. This is the iliotibial band or the iliotibial tract, going from the ilium down to the tibia. This entire structure is the ITB, iliotibial band or iliotibial tract. So there's that Starbucks muscle, the TFL, right? There's the tensa fascia lata. It originates on the anterior superior iliac spine and inserts right there on the ITB. Short muscle, but a very, very long attachment site. But there's another muscle that attaches to the ITB. It's this one right here, the gluteus maximus. You see that? So gluteus maximus is your primary hip extensor. This is your stairmaster muscle. This is your squatting muscle when you do squats and you go from a squatting position and you stand up, or you go from your chair to standing up. That's the gluteus maximus, primary hip extensor, whereas gluteus medius is your primary hip abductor, abduction. It's your primary hip abductor. That's your gluteus medius. Now, because we're looking at the thigh, this is anterior, this is posterior, but we're looking at it from the lateral view, we can see the lateral quadricep. The lateral quadricep is the vastus lateralis. Remember, there was a vastus lateralis, vastus medialis, and a vastus intermedius with the superficial rectus femoris. Those were the four quadricep muscles. Those were going to extend the knee. So what's going to flex the knee? The antagonistic muscles, right? So agonist and antagonist. Agonists are the primary movers. Antagonists are going to do the opposite. So if they're doing the opposite, they have to be on opposite sides of the bone. So if the quads are extending the knee, your hamstrings back here are going to flex the knee. And the lateral hamstring is the bicep femoris. We'll have a better look at this when we rotate the hip from the posterior. Okay, let's look at the lateral leg. We looked at the anterior compartment before. That's where the tibialis anterior was and the extensor digitorum. On the posterior side, we saw the gastrocs and the soleus. There's the gastrocnemius. Here's the soleus. They both attach to the calcaneus by way of the calcaneal tendon, aka Achilles tendon. It is the most commonly ruptured tendon in the human body. When the Achilles tendon ruptures, the gastrocs balls up. You'll get this little ball right up here in the calf. Very, very painful. I've seen a number of my patients get these Achilles tendon ruptures, not from athletic use, believe it or not, but during the winter months, I see it more. When people get these bronchitises, we saw a lot of it more pre-pandemic, where I would see at least half a dozen of these, primarily a result of antibiotic overuse. There are certain antibiotics that create tendinopathies. So you really have to do your research and look at adverse reactions. Many of them damage mitochondria. And remember, where we have the most mitochondria is where muscles and tendons are. So be very, very careful with certain classification of antibiotics. Be sure that if you are on them and the adverse or side effect is tendinopathies or ruptured tendons, you definitely don't want to do anything too aggressive. So the gastrocs and soleus plantar flex the foot. They attach to the calcaneus. On the lateral side of the leg are the Peroneus brothers. So the Peroneus Sometimes it's also called fibularis. So this peroneus longus and peroneus brevis are also referred to as fibularis longus and fibularis brevis because it's on the fibular side, which is the lateral leg of the bone. The peroneus longus and brevis, since they are on the lateral side of the foot, they evert the foot. Remember the tibialis anterior that was in the front but attached to the first metatarsal and first cuneiform? That inverted the foot. The peroneus brothers here evert the foot. Okay, let's go back and let's look at the posterior side here. So we looked at the front, we looked at the side. Now let's take a look at what we can see superficially from the posterior side. So here's the lower lumbar, here's the sacrum, this is the left lower extremity. Here's the gluteus maximus, primary hip extensor, and now we can see the hamstrings in the back. There are 3 hamstrings. There's one on the lateral side, which is the bicep femoris, and then there's 2 on the medial side of the thigh, and those are the semisisters, the semitendinosus and semimembranosus. The semitendinosus, membranosus, and bicep femoris, those are the 3 hamstrings. Those are the 3 hamstrings. 2 on the medial side, the semisisters, 1 on the lateral side, the bicep femoris. Now the term bicep means 2, bi means 2, so there's a short head and a long head. The same thing holds true when you do the upper extremity and you learn about the biceps brachii. There's a short head and a long head of that as well. So what we're seeing here is a long head, the short head is deeper. You can see now a little bit of the gracilis, which is the second longest muscle in the body, and you can see where it inserts. Remember that pes anserine, I said means goosefoot. And then we have the semitendinosus, that one also, which is superficial, right here, the semitendinosus, the gracilis, and the sartorius, right there, that's the sartorius. 1, 2, 3 muscles make up the pes anserine. They all have the same insertion. The sartorius, the gracilis, and the semitendinosus all have the same common insertion site. The hamstrings are going to bend the knee. They're going to flex the knee. They cross the joint, they have to act on it. But so can the gastrocs. The gastrocnemius also flexes the knee. Why? Because it crosses it. It actually originates on the lower end of the tibia, but its primary action is going to be at the ankle. It's going to plantar flex the ankle. But because it crosses the knee, it can also flex the knee. Adjacent to the gastrocnemius is the soleus. Now, when we do the gastrocnemius, there's 2 heads to it. So there's a medial head of the gastrocnemius and a lateral head of the gastrocnemius. There's 2 heads. The other thing I want you to pay attention to, we're going to go to another view where the gluteus maximus can be dissected away. And when it's taken away, we'll be able to see the origin of the hamstrings. The hamstring origin happens to be on a bone that you needed to learn for osteology called the ischial tuberosity. So the hamstrings originate on the ischial tuberosity. The gluteus maximus is the primary hip extensor. The hamstrings are the primary knee flexor. But because the hamstrings cross the hip joint, they can also extend the hip. They're not super strong at it, they're not powerful at it, but they can be synergistic in hip extension. So gluteus maximus would be primary hip extensor, synergistic would be the hamstrings that can extend the hip. Synergy means it helps it along, synergistic. The hamstrings are primary knee flexors, but the gastrocnemius are synergistic. They help it along. Okay, let's go back one. Okay, and so we've done the front of the entire lower extremity. We did the lateral side. We did the posterior side. Let's look at the inside, the medial aspect, and see what we can see. So in the front of the hip is the psoas major. It originates on the lower vertebrae, even the discs, right? Here's L4, here's L5, here's sacral segment 1. So here's the L5, S1 disc right there. The psoas major attaches to the vertebral bodies and the discs. So if there's a hard contraction of this muscle, you can actually herniate discs. I see a lot of people doing forceful sit-ups that end up showing up in my office for blown out discs from aggressive exercise from psoas major tugging on the spine. Sit-ups are not the best exercise to strengthen the abs. The abdominal muscles are truly spine stabilizers. So doing more of a plank movement is much more beneficial to strengthen the abdominal muscles than acceleration exercises. The rectus abdominis and the obliques, those were not fast twitch fibers. They're not designed for hard, rapid, acceleratory type of movements. They were designed for stabilization. That's why planks really train them well. So that's hip flexor. The hip extensor is on the opposite side. That's your gluteus maximus. On the posterior part of the thigh, we're looking at it medially, right? This is the inside, and that's why we see the semicisters, the semitendinosus and membranosus. It is the semitendinosus, which is right here, that makes the insertion site to be the same as the gracilis insertion site and makes it the same as the Sartorius insertion site. That's the goosefoot, the pes anserine, which is just medial. This is the tibial tubercle. That's the patella. That's the tibial tubercle. So medial and posterior is right there. It's the pes anserine. Sartorius, longest muscle in the body. Gracilis, second longest muscle in the body. Your adductor longus is the muscle that is most commonly, like when someone says they have a groin pull from soccer or from a hard punt in football and they pull their groin, it's typically a very, very bad strain of the adductor longus. The largest adductor is called the adductor magnus. Some of the anatomy books will dissect it and create 3 divisions of it, an anterior division, middle division, and posterior. That's how massive that muscle is. Because we're looking at the thigh from the inside, there's your inner quadricep called the vastus medialis. Remember, vastus medialis, vastus lateralis, vastus intermedius, and the rectus femoris. Looking at the inside of the leg, but again, posterior. Here's anterior. So posteriorly, this is the medial head of the gastrocnemius. That's your Achilles tendon attaching to the calcaneus. And here's the soleus. It's important to know that the gastrocnemius crosses the knee joint because its origin is on the femoral condyles, but the soleus does not cross the knee. It originates on the leg, on the tibia, and it has the same insertion site on the calcaneus. So powerful plantar flexors. You'll notice that when people train and exercise their calf, sometimes you see people doing plantar flexion while they're standing with the legs extended, and sometimes they'll have weight on top of their knee and they do plantar flexion while they're in a seated position, and that changes which muscle which muscle is actively contracting, whether the leg is extended or whether the knee is flexed. When the knee is flexed, you're working primarily the soleus. When the leg is extended, you're working primarily the gastrocnemius. Underneath the foot, it's important to know the foot has the arch of the foot, and underneath the foot, there's the plantar fascia, which helps to maintain the architecture, that nice medial longitudinal arch of the foot. When the arch is too high, they call it pes cavus, and when the arch is too low and it's flat, they call it pes planus. And I will say in my office, when I assess a person's foot, which I always do on a first exam with every patient, despite where their pain syndrome or problem may be. Doesn't matter if it's the shoulder, the neck, the mid back, the lower back. I start the exam at the foot doing a thermographic 3D foot scan. And it can detect whether they have flat feet or high arches. Because remember, you're standing on your feet. So whatever is happening at the pedal foundation, pedal means foot, whatever is happening at the pedal foundation dictates what happens at the knee, the hips, the lumbar spine, thoracic, even all the way to the cervical curve and rounding of the shoulders. There's a connection for the feet all the way up to the neck and the head. I've seen people with meniscal tears that were never from any type of macro trauma. Like a lot of people get these terrible triad tears of the knee where the medial meniscus blows and the medial cruciate ligament blows and the the medial collateral ligament, anterior cruciate ligament, and medial meniscus all blow out. I've seen it happen from just having flat feet for many years. Okay, so 7 out of 10 people are going to be pronated on their feet. And that will start to rotate the tibia, and it starts to slowly create a biochemical degradation of the meniscus. And as people get older, they start to get primarily the medial meniscus will blow out first. The first thing to do for these people is really get them in a nice, flexible orthotic. Not a hard shelled orthotic, but a soft, flexible one. Seems to be much, much better for people. Okay, let's take a look and see what else we have there. All right, so what I want to do is I want to start from that posterior. Remember here when I said if we remove the gluteus maximus, we can see the hamstrings a little bit better. So I want to do that right now. So here, the gluteus maximus, you can see right there, it's cut. So the gluteus maximus is cut, and look what's deep to it. There's the infamous sciatic nerve, right? The sciatic nerve pierces inferior to this muscle called the piriformis. These muscles, these short muscles that you see here, piriformis, superior gemellus, inferior gemellus, obturator internus, quadratus femoris, these are all of these short muscles are external rotators of the hip or lateral rotators of the hip. They're synonymous terms. Lateral rotation and external rotation basically means the feet are flaring out, but the femur is laterally rotating so that the greater trochanters are rotating out. That's lateral rotation. Notice when the piriformis, when this thickens or is in spasm, it can put pressure on that sciatic nerve. So when it does, we call it Piriformis Syndrome. Piriformis Syndrome is a type of sciatica. This type of sciatica tends to create sciatica that stops right at the knee. You can see the sciatic nerve right here behind the knee. When it goes past the knee into the calf or foot, it's pretty much rules out Piriformis Syndrome and tells us that it's a lumbar disc, like an L5 or L4 nerve root irritation, because the sciatic nerve does originate at L4 and L5 of the lumbar spine. Okay, so the gluteus maximus is cut. We could see those deep lateral rotators. Piriformis is a famous one, right? But here is the ischial tuberosity, and that's the origin of the hamstrings. So there's your bicep femoris, long head. Right there is the bicep femoris, short head. And then medially are the semisisters. There's your semitendinosus and semimembranosus. So now you can see by this image why it can extend the hip, right? It's on the posterior part of the hip, so it can extend the hip. It crosses the knee posteriorly, so it flexes the knee. Extension of the hip, flexion of the knee, that is the primary action of the hamstrings. Okay, now let's just look at a close-up view of that. Again, there's the gluteus maximus cut, that's your primary hip extensor. There's your gluteus medius, that's your hip abductor. Here's your piriformis, that's your sciatic nerve. And then you have a gemellus superior, gemellus inferior, quadratus femoris, obturator internus. There's also an obturator externus. You just can't see it. It's on the other side. But those 6 muscles are the lateral rotators of the hip, aka external rotators. Here's your hamstrings. That's your ischial tuberosity. Okay, let's look at we went through the quadricep muscles from the front. Now what we're looking at, let me just remind you here, when we look at the quadriceps, there's your vastus lateralis, your vastus medialis, rectus femoris. What did I say was deep to rectus femoris? The third vastus muscle, which is now here. So here is the vastus lateralis. Here's your vastus medialis, and there's the vastus intermedius. So what was cut so that we can see it? The rectus femoris, which is here. That's the proximal tendon of rectus femoris. There's the distal tendon. The quad's attached to the patella only to make its final destination to the tibial tuberosity. So what are these two that are cut? This one would have been the Sartorius, that would have been the TFL. See, the tensa fascia lata goes from here to there. You can see it cut right here as well. And then that's your ITB, the iliotibial band. The Sartorius right there, that originates on the anterior superior iliac spine, whereas the rectus femoris originates on the anterior inferior iliac spine. This is psoas major, this is iliacus, where they travel underneath the inguinal ligament. They insert on the lesser trochanter as the iliopsoas, lesser trochanter. There's your adductor longus, that's the groin pull muscle, and the superior to it is the pectineus. They're both adductors. Pectineus is pretty short. Adductor longus, pretty long. Okay, let's look at the lower leg. So remember the peroneus, which is lateral ankle, lateral leg to the lateral ankle, can also be called the fibularis longus because it's on the fibular side. Tibia is medial, fibula is lateral. This large belly here in the front is the tibialis anterior. We said it's your dorsiflexor, foot invertor, tibialis anterior, dorsiflexor, L4. Remember that? So that's your tibialis anterior. Extensor digitorum longus, another big muscle in the front. It goes to toes 2, 3, 4, and 5. Then you have an extensor hallucis longus. That's this right here. It's this, and it goes right here to the great toe. That's the extensor Hallucis longus. It's beneath the EDL. It's beneath this, the EDL, but it goes right there to the great toe. It's one of the muscles involved with bunion formation. And that's because if you look at the angle, right, the toe is on the inside, but the belly of the muscle is more lateral. So when you have a line of pull lateral to medial, it's going to pull this toe laterally, and you get a bunion formation right here. So anything that's on the anterior compartment is innervated by the deep peroneal nerve. You can see it here. And they dorsiflex the foot. If it's a muscle that's on the inside, real pure internal medial muscle, it's an inverter. And if it's on the outside, it's an everter. So let's look at the lateral leg here. Here's the ankle. That's the lateral malleolus. So here's Peroneus longus and Peroneus brevis. Longus is much more superficial. Brevis is on the outer perimeter of it. But here's the longus. If we follow it down, here's the tendon of it. And it goes underneath the foot like a stirrup to the medial side, to the first cuneiform and first metatarsal, which is the same insertion site as Tibialis Anterior, which is in the front. So that's the Peroneus longus. Peroneus brevis, okay, short little muscle and attaches right here, base of the fifth metatarsal. You can see their lateral leg muscles, they're everters of the foot. Okay. Your gastrocnemius and your soleus, those are posterior muscles. There's your Achilles tendon attaching to the calcaneus. Plantar flexors. Plantar flexors. Let's look at the posterior leg again. Now what we did here, just to show you, let's go zoom out a little bit. Here is the lateral head of the gastrocnemius. Here would have been the medial head. So you see it says gastrocnemius and medial head removed. This is not the medial head. This is the lateral head. The arrow should be pointing to this gap. What's missing here is the medial head of the gastrocnemius. So that medial head of the gastrocnemius is dissected, and look what you can see really well. The soleus. Pretty large muscle, powerful foot plantar flexor. This muscle here is the popliteus. It's the key that unlocks the knee. It's the key that unlocks the knee. Meaning the tibia, in order to initiate knee flexion, for you to bend your knee, you can't bend it first. You have to unlock it. The knee locks when it's extended. So this little diagonal muscle called the popliteus medially rotates the tibia just a little bit. And when it medially rotates the tibia just a little bit, now it's unlocked, and then your knee can bend and you can flex it. So you have the soleus, the gastrocnemius, and 1/3 muscle here. It's not labeled, but you can see the tendon right here. The belly of it is right there. This is called the plantaris. So you have the gastrocs, the soleus, and this long plantaris tendon. The plantaris, gastrocs, and soleus, they all have the same insertion. They all make up the Achilles tendon or calcaneal tendon, the one that's most commonly ruptured. And they all plantar flex the foot or plantar flex the ankle. These are all innervated by this nerve that you see back here called the tibial nerve. And it's really an extension of the sciatic nerve. One of the branches that comes off of the tibial nerve is called, one of the branches off the sciatic nerve is called the tibial nerve. and it goes all the way down. You can see it here too. That's why sciatica can send numbness or tingling down into the foot. Okay. Now, deep to the gastrocs, the soleus, and the plantaris, we have three other muscles. There's your popliteus, by the way, that I mentioned, the key that unlocks the knee. That's the popliteus. Here's your sciatic nerve at the knee. It goes down, becomes the tibial nerve to the inner ankle, and it goes underneath the foot. So these three muscles, tibialis posterior, right there, flexor digitorum longus, right here, and flexor hallucis longus here, those three bellies go towards the inner ankle just behind the medial malleolus. These three muscles are posterior leg muscles, but they travel behind the medial malleolus and go underneath the foot, okay, along with the tibial artery and tibial nerve. So along the inside of the ankle, let me see if I have another view of the inside of the ankle. Let me go here for a second. So here, if we dissected these away, you can see here's the medial malleolus. Those three muscles, including the artery and nerve, are right back here. Okay, and I call them Tom, Dick, and Harry. Tom, Dick, and Harry. T, D, N, artery nerve, A-N, H, Harry for hallucis. So the T, this tendon right here, just behind the medial malleolus, that's T for tibialis posterior. That's Tom. Tom, Dick, that's flexor digitorum longus. So you have Tom, Dick, and A-N, tibial artery, tibial nerve, A-N, artery nerve, tibial artery, tibial nerve. So you have Tom, Dick, and A-N, Harry, flexor hallucis longus. Again, Tom, Dick, and Harry. Tibialis posterior, that's Tom. Flexor digitorum longus, the D for digitorum. AN, tibial artery, tibial nerve. And then H for Harry, flexor hallucis longus. It's a little silly way to remember them, but the superficial muscles are the gastrocnemius and the soleus and that plantaris. When you dissect those and pull them away, then you could see Tom, Dick, and Harry from this view here. There's tibialis posterior, there's flexor digitorum longus, there's flexor hallucis longus, but I was showing you Tom, Dick, and Harry at this from this perspective, posterior to the medial malleolus. Okay, so let me stop the recording here and see if you have any questions for me. So that was pretty short. I said it was going to be an hour, and it was an hour, but that was purely the lower extremity. What I'll do is I will send out a video of me doing the upper extremity. I just didn't want to keep you guys here for another hour. If you want me to go on and lecture for another hour, I certainly can, but I saw many, many students last week started to fade out. And it's kind of tricky, you know. I understand, like if we're talking about YouTube videos, I understand students much rather prefer 15-minute videos, 12-minute videos. I get it. But when you're doing a live lecture, most instructors, including myself, we're accustomed to lecturing for 2 hours straight. So for me, an hour, to cut it in an hour is pretty short. But I understand everyone has, you know, a certain tolerance as to how much they can absorb in one sitting. So I'll stop there at the hour. I will hang on here and handle any questions that you may have on any of that information or anything about the course in general. I'll be more than happy to answer those questions. I will upload this video probably within the next hour. And within the next hour, I will also send out a video on the lower extremity. Okay. It looks like we had a few people show up. One of the students had asked earlier, when I took the lab portion, I didn't do too hot, and I didn't even recognize or know where those pictures came from. But what we did is clearly showed where those pictures came from, which is the APR. And that's why it's really important during that first week where I made those videos and showed the students, here's the moving parts of the course, here's how you access the textbook, here's how you access the quizzes and the APR. And the APR and the quizzes are linked. So if you're jumping in to just take the quiz in lab based on maybe what you read in a textbook, it's nearly impossible to do well. If you do the APR exercises first, while that's fresh in your mind, and then jump to the quiz, you'll do much better. Okay? And if anyone needs assistance on how to do that, just hang on, let me know, and I'll walk you through how to do it. So does anyone have any questions? I see Annie, Ashley, Edwin, Elizabeth, Heather, Jesus, Julie, Malin, Sansia, and Shantae. Any questions? Aside from the test banks, you got to read through it. There's no, I sent a video out yesterday. I think it was on muscle physiology. So I did a pretty good overview on that. Yeah, there's no shortcuts on the lecture portion. And that really is just, browsing through the online textbook to get comfortable with some of that information. Yeah, I can't do a review for that because everyone gets different questions, and that's what makes that part so difficult. So I wish I had a better answer on that. The lecture portion, though, to understand the lecture portion, you have to be reading the discussion board. Okay? To understand the lecture, that's what the discussion board discusses. A lot of things that show up on the lecture exam. But you guys are kind of teaching that component to each other. Let me just see what some of the other questions that popped up here. I couldn't. How do I format my discussion to not sound like I'm writing things straight out of the book? How do I format it not to sound like I'm okay? So when it comes to answering your primary question, yes, there is going to be a bit of that comes from the book. There's going to be part of it, but you want to use your own language where you can. The critical thinking portion, right, in terms of that grade, when I'm looking at the rubric, there's an even distribution. And maybe, let's say the critical thinking is maximum 10 points, I think, maybe for question 2. If there's an unequal distribution or the critical thinking part of it was the weaker part, then some of you maybe didn't earn the full points to that. You may have got, instead of 10, maybe you got 9 or 8, that it was proficient. Some students just did the research part and forgot to do the critical thinking part. Some students forgot to include the word count to it. So all those parts are really important. It's just following the instructions to it. have your research, label it, have your critical thinking, label it, have your word count, and your references at the bottom. But overall, most students did very, very well. Perhaps they just forgot to separate things. And it makes my grading it so much easier. When I see one paragraph, I have to really pick through it and I have to go, was that the critical thinking or no, right? It's really hard and I don't want to have to guess. So separating them really is important. When you're addressing your classmates and you're responding, make sure you address your classmates. I think some students were still getting confused that you're doing three main answers to three different questions, and you're really doing one, and then you're adding some additional information perhaps to your classmates' work, right? To expand on it. That's all. And then make it relevant to you. That's the critical thinking portion. How do you make it relevant? How did you learn it? How did you memorize it? Some of the students that were doing the weekly summary for the extra credit, I've been reading a lot of those, and a lot of students say, you know, some of it is hard to memorize. And the concept to memorization seems like a real task. But if you think about, you know, if I have a song on iTunes and I'm playing it in the office, I don't memorize it the first time I hear it. It's hearing it 2 or 3 times, then I start to learn the lyrics, right? So me going through the muscles on one website on one page and you seeing it that way for the first time, that's like prime. That's like painting the wall, but that's the prime. And then, okay, you're going to go to the APR, which I'll go over because it looks like Edwin wanted me to go over that, and I will. Then you'll do the APR, that'll be the second time. And then maybe looking at the atlas is the third. By then, there's repetition. And that's how you, I don't want to use the word memorize, but it's just through the repetition, you get much more familiar with the content. But you're doing a lot of information in a short period of time, so don't be so hard on yourselves. You know, to try and grasp all of this information in 1 week is a big ask. It really is. Can I go over? Edwin left. Okay. He wanted me to go over how to get to the APR, but he left. Maybe he's coming back. Anyone else? Any advice on scoring better on exam? It depends on which one. If you're talking about lecture exam, I gave to some students the test bank. So you may want to reach out to some of your classmates if you didn't get the test bank. The test bank is not an easy task, right? Some people are like, oh, we got all the questions, and it's true. You got all the questions, but you're only getting 25, right, questions on a test, and there could be 200 or 300 questions in a test bank. So that's a lot. So you could use the test bank, look at the questions, and read around the questions so you understand the answers. That's a way. And looking at some of those videos, there are some videos that the department also puts, which are very short tutorials. And YouTube is a good friend. And make sure you watch my videos. The videos that I put out there on muscles, I'm going to send, you know, 2 or 3 more on, I'm going to send one out that's of the face and the neck and the, you know, the facial muscles and some of the neck muscles. And then we'll do one of the upper extremity. Make sure you watch them. I don't put them out and send them out for me. I know the information already. I put it there for you, but not everyone watches them. You know, I look at some of the stats. Sometimes you'll watch 10 minutes of it, and it's like an hour. So you really got to make the time to watch it. Let me see. What was that last one? Okay, I definitely need to know how to get to the APR as well. All right, so let's do that. Who here has the test bank that you can share? Okay, the test bank. Great, thank you, Annie. Thank you so much for helping out, Shantae. So during the week one, Shantae, during week one, I was very open with the students and said, I wish there was more I could do for you in terms of helping my students master the lecturing information. But I don't know what Shantae's 25 questions are going to be and what Annie's 25 questions are going to be, or Jesus's. So when I write the test, it's so much easier for me to do a review. But I don't. I don't write those exams. They're publisher-based exams, and they spit out differently for each student. So the best I could do for a study guide was send out the test bank questions. Unfortunately, I've tried several times to send out the test bank questions through Blackboard, and students can never open them up. They come up encrypted. The only way I was able to succeed was through outside of Blackboard using a Gmail address or something. And that's how we mastered it during week one. So you'll be getting that. Okay, let me show you how you access the APR, okay? Let me record this part too, and I'll see if I can, let me see if I can record this here. Let's see if we can get this back up. Okay, let's see if I can record this again. Oh, I'm still recording. This is great. Okay, so I'm still recording it. So let's go and show you how you can find this. So when you go to your Connect, over here you have your ebook, you have your atlas, and then you have your APR, the Anatomy and Physiology Revealed. So when you click on that, it takes you to this. When you go in the upper left, you'll see select a module. Let's say we're going to do, let's just look at skeleton.
Can't see your screen.
Oh, okay. Thank you. Let's go back. Let me do my screen share. Okay, hopefully you can see my screen now.
Yes.
Great. So when you go to Connect, this is where you access your quizzes, right, for week 1, 2, 3, and 4. Here's the ebook, here's the atlas, and here's the APR, the Anatomy and Physiology Revealed. So when you click on that, it takes you to something that looks like this. You can go in the upper left where it says select module. So let's say last week we did the skeleton, right? So when you click on the skeleton, and let's say you want to look at the atlas. So here's the atlas vertebra. Doesn't this look familiar from one of your quiz questions? What bone is this? Some of you got this one for axis. Some of you got atlas, right? The way it highlights it with that funky green. So here's the atlas, and then you just click on this, right? So here's the lateral mass, superior articulating facet, transverse process. You got to go through these. Let's look at muscles. Let's select the topic. Let's say we're doing, let's go to femur. Let's look, oh, actually, let's go back to muscles for a second. And topic, let's go to shoulder and arm, because this will be what my next video comes from. Select view, we'll look at it from the posterior. So here's what you get. And then you can dissect the layer. So on the bottom left here, I'm starting to peel away. I'm starting to go down. And now I could see some muscles over here. So let me click on the deltoid. There it is. Here's infraspinatus. There's the latissimus dorsi. There's the long head of the triceps. There's the medial head. There's the lateral head, right? So these pictures are going to pop up. I'm sure of it. They're going to show up on the test. Someone's going to get this, and it's going to ask, what is this muscle? And you'll have to identify it. Some may get this one, and it'll say, what's the action of this muscle? Some may get this one, and it'll say, what's the insertion of this muscle? Greater tubercle. What's the origin of this muscle? Supraspinous fossa. Some may get this muscle. What is the origin? Infraspinous fossa. Okay, so you can play around with these so you can dissect, so you can see a little bit better, right? It'll probably ask it like this on a test. It'll isolate just that. What is that? Okay, so this is the APR. You want to get really comfortable. If you're taking your lab quizzes without doing the APR exercises, well, that explains why some of the grades are poor. But it's, you know, my first week, I made sure I sent out a video and I said, watch my videos. I don't want anyone getting burned here, right? You got to watch them, my introductory videos. And it said APR and the quizzes go hand in hand. Make sure you incorporate them together. Okay, let's stop the screen share and let me stop the recording.